Hello, my name is Jad Dandashi. I am a third-year emergency medicine resident at Henry Ford Hospital in Detroit. And today I'll be presenting the abstract titled Derivation and Validation of the ED-SAS score for very early prediction of mortality and morbidity with acute pancreatitis. I have no disclosures. So, acute pancreatitis is a disease that we are all quite familiar with and one of significant morbidity and mortality. Recently, in the past few decades, the incidence of acute pancreatitis has actually risen globally, and approximately 1% of patients with the diagnosis of acute pancreatitis will experience mortality, and up to 30% of patients with infected pancreatic necrosis unfortunately expire. There are multiple validated prognostic scoring systems used for pancreatitis. Some of them you may all be familiar with, including Ranson criteria, the Apache 2 score, and the BISAP score. However, these scores typically require at least 24 hours worth of admission time for the patient to collect particular parameters and lab studies. And therefore, it is difficult to apply any of them in the acute emergency department setting with the presentation of a patient who is undifferentiated or early diagnosis of pancreatitis. The objective of this study was to establish a simple prognostic assessment of acute pancreatitis that is applicable in the emergency department to be able to risk stratify our emergency medicine patient cohort. The study design is a retrospective study that was had taken place in two academic health systems. Vanderbilt University Medical Center, which is a level 1 trauma center, and Henry Ford Hospital, which is also another level 1 trauma center, and included all subsequent additional sites within those hospital systems. For the selection of participants, I have listed here the eligibility criteria: patients who are greater than or equal to 18 years of age, with a diagnosis of acute pancreatitis made in the emergency department, and those who required hospital admission within 24 hours of presentation to the emergency department. Exclusion criteria included a diagnosis of chronic pancreatitis or hepatic failure, or those patients with a serum lipase less than 3 times the upper limit of normal reference range, which is a well-accepted diagnostic criteria for acute pancreatitis. And patients with repeated ED presentations for acute pancreatitis over a 90-day interval were also excluded. Outcomes that were evaluated in the study: primary outcome being 30-day mortality, and secondary outcomes including 180-day mortality and presence of either respiratory failure, sepsis, or kidney injury. This slide shows the demographics of the patient population that was included in the study. The primary outcome for the study was ultimately chosen to be 30-day mortality. Secondary outcomes included 180-day mortality, the presence of sepsis, acute kidney injury, respiratory failure, mechanical ventilation, initiation of dialysis, ICU admission, and mean number of length of stay days. The predictor variables that were chosen to be included in the initial data collection were based off of prior known variables known to be associated with mortality from acute pancreatitis based on existing disease models. These included gender, age, race, hematocrit, SpO2, SIRS criteria, and the Charlson comorbidity index. A univariate linear regression and then subsequently a multivariate linear regression was performed in order to ascertain clinically statistically significant predictors of 30-day mortality, and the criteria that ultimately achieved a p of less than 0.1 are highlighted here with the asterisks next to them in the table, and they included age greater than 60 years, an SpO2 of less than 96%, and greater than or equal to 2 SIRS criteria. These 3 statistically significant criteria were ultimately included in the ED-SAS score, and the criteria themselves are what constitute the SAS portion of the title. So SpO2 less than 96%, age greater than 60 years, and greater than or equal to 2 SIRS criteria. Each criteria was equally weighted, with 1 point being granted if they are present. So if any of the criteria were present in a patient, they would receive 1 point for each of the criteria, or 0 if they weren't present. Therefore, the final range of the score is 0 to 3. We performed a logistic regression for these score categories, with a score of 0 being the reference, to assess odds of death and all secondary outcomes, and further applied the derived predictor score to the validation sample to assess its association with primary and secondary outcomes. Ultimately, the model yielded the values that you see in the table on this slide, with 30-day mortality and 180 mortality odds ratios continuing to increase with higher scores on the ED-SAS scale. Ultimately, we were able to derive and validate a simple prognostic tool using only 3 variables that are quite readily attainable and available within most emergency department settings, in order to aid with risk stratification of our patients coming in with acute pancreatitis. That more well-known and traditional scoring systems have unable to be applied in the emergency department, given the numerous number of variables required and the length of time that the patient has to be admitted to acquire those variables. Ultimately, it was predictive of mortality, as with higher ED-SAS scores translating into an increased odds ratio of 30-day mortality in patients diagnosed with acute pancreatitis. And it relied on using pulse oximetry in this study, given that there are infrequent use of arterial blood gases in the ED for most of these patients. Our study did have some limitations. Obviously, it was a retrospective chart review cohort study, and there was not a direct comparison done between ED-SAS score and other common ED predictors of mortality. There's also always concern for loss to follow-up, which is our study is not immune from. And it relied on EHR data to determine the 30-day and 180-day mortality, and there was no actual direct contact with patients or patients' families to derive this. Also, the study itself is not, or the ED-SAS score itself is not a tool to be used to determine who is safe for ED discharge, but rather a tool to be used to risk stratify patients in terms of disposition and as well as intensity of care within the emergency department. And finally, we did not compare the ED-SAS score to clinical gestalt. So in conclusion, we were able to derive a simple prognostication tool that is able to be used in the emergency department to risk stratify our patients coming in with a diagnosis of acute pancreatitis. Our study was able to be completed with the help of all the authors listed here. And these are all the references used within our study. Thank you.